Is my slides visible, sir?
Not as of now. Yes,
Yes.
now it is full screen.
Yes.
Please start the presentation mode.
Krishna, make it full screen, please.
Yes, sir.
Yes,
Move
slides
it.
are visible. You are audible. Dr. Rawat sir, you can please take over, sir.
हाँ, मूव करिए, एक बार मूव करिए इसको. Move it. Yes, please. Stop कर दीजिए. Dr. Modi, you can take over, please. You can stop sharing. Dr. Modi. Yes, so I think Dr. Modi is not there. So, good evening all. Welcome to this tradition of advanced pulmonary clinic, which we are organizing every Monday. Last Monday every month, in which we discuss cases on pediatric pulmonology by DM residents and fellows. And for this edition, we are thankful to Dr. Matthew for allowing to present the case from PGI Chandigarh, and it will be presented by Dr. M.G. Ramakrishnan. The expert for today's session will be Dr. Kishan Chug and Dr. Goel, and Dr. Kamal Singhal would moderate the session. I'll request Dr. Kamal Singhal to take over the case.
Thank you, sir. So without any ado, let's start with the presentation. I'll request Dr. Ramakrishna to start with the presentation. Dr. Goel is there and Dr. Chug is there. We can start. Yes, Dr. Ramakrishna, please proceed.
Yes, sir. Good evening, everyone. Myself, Dr. M.G. Ramakrishnan, a second year DM senior resident from Pediatric Pulmonology Unit from APC, PJMR Chandigarh. I would like to present the case history of a child, Miss A. Age while presenting to us is 9-year, 9-month-old girl, presented to us with chief complaints of fever for 15 days, cough for 12 days, fast breathing for 6 days, and abdomen pain for 6 days. So, child was apparently well 15 days back, and child started developing fever initially, which was high grade, 104 degree Fahrenheit, daily documented up to 2 to 3 spikes, relieved by paracetamol, associated with chills and rigor. Then, by day 3 of illness, child developed a dry cough, which was non-paroxysmal, and there was no diurnal or postural variation of cough, and it was associated with post-tussive vomiting. Then gradually the child developed fast breathing in the form of retractions associated with lethargy, but there was no cyanosis. And child was refusing. There is reduced appetite when the child started to have this breathing difficulty. And then along with the breathing difficulty, child also complained of abdomen pain, which was diffuse, gradually decreased over the intensity over the 6 days was gradually reducing, but it was still persistent. There was no relation to food intake. There was no constipation, obstipation, or vomiting. Also, child also had a history of maculopapular rash, which was itchy in the form of all over the tongue. 6 days prior to the presentation to us, that is approximately at day 9 of illness, which was not vesicular. There initially found in the trunk. The mother couldn't able to recall whether about the order of appearance of the rash. The mother noticed the rash over the trunk, but it was transiently resolved within 2 days. It was associated with lip and gum ulcer, which was not associated with bleeding. In view of this ulcer, child was unable to eat food. However, by over-the-counter medications, some ointment, the ulcer has been resolved after 3 days. Mother also noticed the history of weight loss in the form of loosening of previously used clothes, approximately about 1 kg in the last 2 months, compared to previous records as remembered by the mother. There was no history of any pustules, pyoderma anywhere in the body. There was no history of any jaundice, persistent vomiting, melena, hematemesis, or any bleeding manifestation, or any periorbital edema. There is no history of headache, altered sleep-wake cycle, diplopia, projectile vomiting, or neck pain. There is no history of any lumps or swelling palpable anywhere in the body. There is no history of constipation, obstipation, loose stools, or blood in stools, or any abdominal distension. There is no history of any skin rashes in the form of malar rash, nasal ulcer, alopecia, any hematuria, joint pain, or joint swelling. There was also no history of dry eyes, dry skin, any eyelid rashes, any photosensitive rashes, or any difficulty in using upper limb or lower limb pointing towards any proximal muscle weakness. There is no history of any bluish extremities to cold, thick skin of palm or sole. There is no history of any progressive pallor, previous history of any blood transfusions or any bleeding manifestation. There is no history of any red eyes, oral erythema, or any peeling of skin in fingers or in the perianal region. There is no history of any oral thrush or any abscess requiring incision and drainage, or any interventions like or any surgeries or any interventions that has been surgical intervention requiring anywhere in the body. There is no history of any bone pains or night cries. There was no history of any facial edema, dilated neck veins, pedal edema, or periorbital puffiness. Coming to the treatment history, at day 10 of illness, when the child was taken to private hospital in view of fast breathing difficulty, initially the child was put on nasal prongs of oxygen, but gradually the respiratory distress worsened and the child was put on HH1C support in the private hospital, and in view and also treated with IV antibiotics, piptas, amikacin, azithromycin, and doxy. However, the duration was not mentioned. In view of increasing oxygen requirement, child was shifted to our hospital. Coming to the family history, which was unremarkable, there is no history of any similar illness, no history of any viral prodrome, no history of any chronic cough or any early sibling death or any unexplained death in first degree relatives in the family. In past history, there was bilateral ear discharge noticed 8 months back, which is resolved on its own in 3 days, which was not associated with it, which was a watery discharge, which was there was no any pus discharge, blood, or any discharge of mucus. Birth history: full term normal vaginal delivery, a birth weight of 2.5 kg, and child underwent a smooth perinatal transition. There was no history of any significant birth events in the form of any birth asphyxia or any neonatal jaundice requiring admission in the newborn period. Immunization: child was immunized as per the national immunization schedule. They did not receive any optional vaccines and last received 10 years vaccine. Dietary history: the child was on home based mixed diet with a calorie deficit of 30% and protein deficit of 10%. Developmentally, the child was normal and is studying class 4 now, has a good scholastic performance. Socioeconomic history: according to modified Kupasamy scale, the family was belonging to lower class. So, to summarize, a 9-year, 9-month-old girl with history of 15 days fever, 12 days cough, fast breathing, and abdomen pain for 6 days, with a history of transient maculopapular rash at 9th day of illness, with oral ulcers resolved after medication, and also history of weight loss noticed by the parent, with one episode of bilateral ear discharge resolved with topical drugs, treated outside as pneumonia with antibiotics and oxygen, and referred to us in view of worsening oxygen requirement.
Thank you, Dr. Ram. Just wait. Let us wait. I think we have been through history, and I'm sure the lead discussants would have things in mind. I'll straight away start with Dr. Krishan Chuk, sir. Any clarification that you wish to seek? Any comment? Any
Yes,
clarification, sir?
Dr. Ramakrishna, you told us lots of negative history, no history of this, that long one, huh? Let's go back to those slides where you were telling us negative history.
Yes, sir.
This is it the first one from the negative history?
Yes, sir.
And there are two more, right?
Yes, sir.
Okay. And go back to the previous one. Yeah. So when you're telling us all this, what does it mean? Why are you listing out so many things? What, can you explain each one of them? The first one is pustule pyoderma anywhere in the body. What significance could it have to your case? If we do not know the diagnosis and the clinical examination, we are just at the history stage only. What would be the importance of these negative histories?
Yes, sir. The child presented to us with a history of fever for 15 days and cough for 12 days, pointing towards pneumonia. So, to look for any etiological clue for pneumonia, I would ask about the history of any focus of staphylococcus anywhere in the body, so that any pustule or pyoderma anywhere in the body, which would have been became a staph sepsis and would have gone into cause pneumonia. However,
Agree. Next.
the child had presented with fast breathing at the day 9 of illness, but however, the fever and this focus of fever has started for which was present 1 week prior to the onset of fast breathing. So it could be some tropical fever or any viral fever that would have been start, and the pneumonia would be a secondary bacterial pneumonia, secondary to those transient tropical fever or viral infection leading to a immunosuppression and causing a secondary bacterial pneumonia. For tropical fevers,
Does that happen very often with the ordinary viral infection, that the immune system will be so depressed that the, pneumonia will start? Initially, that it was only fever and no cough, no respiratory distress, not pointing towards pneumonia. You feel that it was an ordinary viral fever, which possibly led to some immunosuppression, and pneumonia developed, bacterial pneumonia. Does
yes,
that
sir.
happen very often, that there is a non-respiratory infection which leads to pneumonia within a few days of, let's say, 3, 4, 5 days?
Yes, sir. Actually, in infants, it is common following a prodrome of measles. In
See,
during out,
measles is a respiratory infection, strictly speaking.
uh,
But here
in
there was no such clue that there is a respiratory infection, and then you say that it could have caused immunosuppression, which led to possible pneumonia,
yes,
superadded bacterial pneumonia. Okay,
yes.
let's move to the next one.
For tropical fevers, the child also presented with abdominal pain. To look for any hepatitis associated with tropical fever like dengue or leptospira, or any dengue or leptospira infection, or any scrub typhus infection, because scrub typhus infection can present as pneumonia or prolonged fever. So, jaundice, persistent vomiting, or any bleeding manifestations like melena or hematemesis, or any signs of capillary leak in the form of periorbital edema has been asked. And to a child also had a history of fever for more than 2 weeks, with history suggestive of history of any weight loss given by the mother. I would also consider pulmonary tuberculosis in the differential, and also I have asked for the signs of dissemination of tuberculosis into other organs in the form of CNS, like headache, altered sleep wake cycle, any diplopia, projectile vomiting, or neck pain pointing towards any ICP. Any lumps or swelling palpable anywhere in the body, to look for any lymph nodal dissemination to lymph nodes. Any constipation, obstipation, loose stools, blood in stools for any abdominal tuberculosis. So these for the differentials for the infective etiology. However, the child has been treated with antibiotics for almost 3 to 4 days outside, but there was no the fever was still persistent. So it could be due to resistant bug, or it can be due to non-infective etiologies like connective tissue or rheumatological disease in the form of scleroderma, the form of systemic lupus erythematosus with serositis, with polyserositis, like pleurisy and peritonitis, or any rheumatological disease causing polyserositis like systemic onset JEA. So I would like to ask the history pointing towards SLE and other rheumatological diseases. So malar rash, nasal ulcer, alopecia, hematuria, joint pain, and joint swelling will point toward to look for features of SLE. Dry eyes,
Patient is a male or a female?
female, sir.
Female. Okay, carry on.
Dry eyes,
Mhm.
dry skin, eyelid rashes, photosensitivity, and proximal muscle weakness. These are dry eyes and dry skin is for features of Sjogren syndrome, eyelid rashes, photosensitivity, and proximal muscle weakness for JDMS. However, in mixed connective tissue diseases, these features of SLE, JDMS, and Sjogren features can overlap. And bluish extremities to cold skin and thick palms and skull, to look for any scleroderma and Raynaud's phenomenon secondary to scleroderma. And coming to the progressive failure previous blood transfusion to look for any features of bone marrow suppression either in a rheumatological disease or thinking in terms of any malignancies, as the fever is being persistent for 15 days, and to look for any malignant etiology causing bone marrow suppression, bleeding manifestation, and any blood transfusion or any pallor. We have thought of and asked these questions. For
Which
red,
particular malignancy are we
yes, sir,
considering?
acute leukemia, sir.
Acute leukemia. So, carry on.
Red eyes, oral erythema, any peeling of skin in fingers or in the perianal region, as the child has persistent fever spike with a transient maculopapular rash. Would also consider Kawasaki disease in this, kept a possibility of Kawasaki disease and ask for these questions to point out towards a particular etiology.
Peeling
And
of skin in Kawasaki occurs at what stage?
sir,
Peeling of skin,
in
Kawasaki
second week,
disease.
in second week of disease, sir.
Second week of the disease.
Yes, sir.
And the patient has had a history of total of 15 days illness, right?
Yes, sir. Yes.
Okay. Carry on.
Yes. For oral thrush or any abscess requiring
Mm-hmm.
oral thrush or any deep-seated abscess to look for any
Carry on.
primary or secondary immunodeficiencies. For bone pains and night cries for malignancies. And facial edema, dilated neck veins, pedal edema, or periorbital opinus. I would ask for two reasons. One, we have also thought of pulmonary tuberculosis in this child, whether it has been disseminated in the form of any TB, pericarditis, or pericardial effusion presenting with cardiac tamponade, or also thought of malignancies like lymphomas with mediastinal adenopathy causing superior mediastinal syndrome. For these two reasons, I have asked for these facial edema, dilated neck veins, pedal edema, and periorbital puffiness.
Mm-hmm. Mm-hmm. That's all. There is another slide on negative histories.
Yes, sir. That's all, sir.
Okay. So somebody has pointed out why so many negative histories. You lose the contact with main symptoms. So negative history should be focused and all, but that is what I wanted to bring out, that in such a patient, if he's been treated elsewhere and no response, it could very well be just the ordinary pneumonia, and suppose anti-staph treatment was not given and now you would give and respond. But if you have to go through all possible causes, yes, this is a good, complete, comprehensive negative history that you have told. And I appreciate the way you have put them, that each line, there are 3, 4 things put together and they all point towards one single or one entity. And that is why there's no confusion. It's not like an undergraduate who starts from top to bottom and starts describing no lymphadenopathy, no this. You put them very nicely. I would like to kind of tell everybody else who's listening, this is the right way of putting the negative histories. Okay, go ahead.
Thank you, sir. So I think the when we say for a particular presentation, we always think of the common first and the uncommon later on. But there will be days when you will suddenly have to face that uncommon also. And the least where you lead the least investment in terms of your approach is the clinical one. So probably words and pointers on history are something very easy to take rather than investigate. So probably it's a good approach. But as sir pointed out, each sentence and each group of words is conveying a particular meaning. It's not it's pointing to a particular direction, so that's good. So Dr. Jagdish.
Dr. Ramakrishna, with your cheap complaints, you have certain differential diagnosis in your mind, and then you start taking negative history. So, means in each and every case, suppose a child who is presented with fever, cough, and respiratory difficulty. So, commonly we'll think of respiratory infection. Okay. So, I just want to know, did you think about atypical infection in this child? Atypical infection with your history only. We are not going into the examination.
Like mycoplasma infections,
Yeah.
disseminated
Because I'm
mycoplasma.
not seeing in any negative history, because sometimes the child might have atypical infection, though respiratory difficulty may be there sometime, and child may have extra pulmonary symptoms also, like abdominal pain, joint pain, and so on.
Yes,
So
sir.
did you think of atypical infection also?
Yes, sir. For disseminated mycoplasma, along with these connective tissue, these negative history has been overlap, but I forgot to mention these jaundice, persistent vomiting. Jaundice can be also an extrapulmonary manifestation of mycoplasma secondary to immunohemolysis. Child may require progressive pallor or any blood transfusion, or any features of joint pain and joint swelling, which was not present in this child.
Okay. One more point regarding weight loss. You said that there was history of weight loss of 1 kg. Okay. And
Yes.
child is around 9 years. So assuming would be around 30 kg or so. Okay. So I don't think it would be more than 5% weight loss. Okay. I'm not sure. Okay. And one more point regarding Kawasaki disease. This child is 9 years. Kawasaki disease usually we see in children less than 5 years. So in more than 9 years, Kawasaki disease, though atypical kind of Kawasaki disease may be there, but it's rare after 5 years. So these are the 2 points which I would like to make. And rest you have nicely presented the history. Thank you.
Thank you, sir.
Thank you, Dr. Jagdish. Dr. Ram, just 2-3 pointers from the chat box that we have. Can you describe the character of this pain? Where is this site? What kind of pain is it?
Yes, sir. The site of the pain is diffuse all over the abdomen. The child was not pointing towards a particular area. There is no history of any sudden choking. There is, as already mentioned, there is no history of any viral prodrome, chronic cough, any fever in the family. The environmental history,
No,
any
I mean pain abdomen. Any specific pointer like colicky, non-colicky, exactly
no, sir.
where,
No,
related
sir.
to meals, all that thing. Because we would want to know what pain abdomen is this. See, it can be because of abdominal cause. It can be from pulmonary cause also. A lower lobe pneumonia can present as pain abdomen. So
Yes,
that's
sir.
what we want to know. Okay, what is this pain abdomen here? Uh,
More like dull aching, sir.
Okay, fine. And I think in history I've told there is no contact with TB around. And environmental history, any history, any biofuels, birds,
No, sir.
any. Okay, fine. Please proceed.
Okay, sir.
Dr. Ram, please proceed.
Yes, sir. Slides are not moving. 1 minute.
Not moving.
Yes, sir.
And share again.
Uh, You can stop sharing and share again in case if you are not able to do it.
So meanwhile, I think the point that how much negative history should be there, probably this is the a way of investigating a case where you have the least amount of the easiest to do. So probably yes, we have reached. Yes,
Yes, sir.
Dr. Ram, please proceed.
Yes, sir. Based on this history, I would like to keep infective etiology. After taking negative history, I would like to keep infective etiologies to be first. So it could be a simple pneumonia or a tropical fever with secondary bacterial pneumonia, or it could be a disseminated pulmonary and abdominal tuberculosis. The points for tropical fever is prolonged fever for more than 2 weeks, along with cough, breathlessness, abdominal pain, and this transient maculopapular rash could be due to some tropical fever in the form of any dengue fever or any scrub typhus that would have been resolved, or a scrub presenting with bacterial pneumonia. uh, Despite antibiotic administration, this being still persistent because of absence of staph cover. For disseminated pulmonary and abdominal tuberculosis, the child having any fever for more than 2 weeks with a history of weight loss, but however it was not documented, with non-response to routine antibacterials. But however, there is no contact with TB, and this cough was 12 days, which is at borderline for to classify as per the NTP definition of more than 2 weeks. But however, there is no history of any other dissemination.
Dr. Ramakrishna, in the first one, you are pointing towards tropical. In that, you have listed dengue fever also. How often does dengue fever present as a pneumonia, cough? Breathlessness can be because of, let's say, pleural effusion. But
Okay.
cough and persistent fever for 2 weeks or so, Should that dengue fever also remain in the list?
Yes, can present, but it is not quite often. But with
Sir
this,
is asking, will it be dengue alone, or you think it is dengue which is complicated with something else? Because dengue alone, do you think it can explain this?
yes, sir, dengue alone can also explain this, sir. With the secondary HLH or anything can explain this.
So there could be complications. You are saying one of them is HLH.
Yes, sir.
Dr. Rama, first I think you should keep the common etiological agent which may lead to pneumonia, and then probably you have to think of other causes. What sir also want to highlight, Chuk sir also want to highlight.
I think
First, we
from the
need to
very
think of common causes, and then we should move towards rare causes.
yes, from the beginning you have come to the DM level instead of passing through the undergraduate and the postgraduate level. Okay, good. Carry on.
Please proceed, Dr. Rama.
Coming to the examination, the child, while presenting vitals, heart rate was 112 per minute. The child is tachycardic and tachypneic of 40 per minute. However, there is no retractions. Pulses were palpable equally in all peripheries with good volume. Blood pressure was 100/60, which was between 50th to 90th centile. Saturation was 60% in room air. However, the saturation was picked up to 95%, requiring oxygen support of NRBM at 10 liters. Anthropometry weight is 30 kgs, which is minus 0.21 Z scores. Height is 136 centimeter, which is minus 0.22 Z scores. BMI is 16.3, which is minus 0.14 Z scores. General examination, there is mild pallor, there is no icterus, no cyanosis, no clubbing, no pedal edema, no lymphadenopathy. Ear canals bilaterally are dry and clean. TM, however, could not be visible. Uh, Throat was normal. Skin, there is no pustules, pyoderma, or any pyoderma scars. PCG scar was absent. There is no oral ulcers, nasal ulcers, alopecia, or malar rash. There is no history of any joint swelling or any deformity. No pyoderma scar, no petechia or purpura. There is no strawberry tongue, red eyes, skin peeling, or any perianal peeling. Coming to the respiratory system examination, in inspection, the trachea appears to be in midline. Apical impulse is not visualized. Chest movements are equal bilaterally. There is no scars or sinuses, and there is no dilated veins or any drooping or any hallowing. On palpation, trachea is in midline. Apex beat is at fifth intercostal space, half inch medial to midclavicular line. Chest movements are equal bilaterally. Tactile vocal fremitus are equal in all lung areas. On percussion, there was a resonant note in all lung areas. However, except dull note was heard in bilateral, inframammary, infrascapular, and interscapular areas. On auscultation, arentry was equal in all areas. There was fine crepitations which were heard along with reduced arentry in bilateral, inframammary, infrascapular, and interscapular areas. However, there is no any wheeze or any bronchial breathing heard. Other system examination on abdomen, liver was palpable 3 centimeter below right costal margin, which was firm, smooth borders, non-tender, span of about 10 centimeters, and the tip of the spleen was palpable, which was 0.5 centimeter below the left costal margin, and which was non-tender. There is no free fluid, no dilated veins or any tenderness. Cardiovascular system, first and second odd sounds were heard normally. There is no murmur, no gallop, no hyperdynamic or apical impulse. Nervous system examination, higher mental functions were normal. There is no cranial nerve deficits. Bulk was equal bilaterally. Tone was normal, proximal and distal bilaterally. Deep tendon reflexes are normally elicitable. There was no meningeal signs. So to summarize, 9-year, 9-month-old girl with 15 days history of cough, 12 days, 15 days history of fever, 12 days history of cough, fast breathing and abdomen pain for 6 days, with history of maculopapular rash, transiently present at 9th day of illness with oral ulcers resolved after medications, with one episode of bilateral ear discharge resolved with topical drugs 8 months back, treated outside as pneumonia with routine antibiotics and oxygen. Examination revealing mild pallor with reduced air entry, dull note, and fine crepitations in bilateral, inframammary, infrascapular, and interscapular areas with firm hepatosplenomegaly.
Thank you, Dr. Ram. Now I think we will take a pause here. I'll request Dr. Jagdish Goyal sir to please come in and for any clarification, any comments.
So with history and examination, it seems child is having means reduced air entry bilaterally and maybe some fluid because this percussion is dull. So probably we are dealing with bilateral pleural effusion and there is firm hepatosplenomegaly. So examination finding is pointing more towards means autoimmune disorder for me. And then definitely TB, I think in TB usually we find unilateral effusion and there is lot of effusion is there in TB because it is hypersensitivity reaction when there is pleural TB. So tuberculosis may be there, but I will not consider. Autoimmunity, I would keep first diagnosis and then HLH pointed out if child is having fever which is unresolving, having hepatosplenomegaly, long-lasting fever, then HLH may also be a possibility. So these are my thoughts, and once more investigations are revealed, then I think we'll be able to.
Thank you, Dr. Jagdish. Thank you so much.
Yeah.
Dr. Krishan Chug, sir.
Dr. Ramakrishna, what would you say about this HLH? Is this a scenario where HLH is a serious consideration?
Sir, uh, the child is having persistent fever spikes with features of severe respiratory distress. So if it was HLH, it could be a serious concern as far as this child is concerned, because child is requiring oxygen support up to NRBM. So there is a severe diffusion limitation and severe hypoxia. Either it would be due to the primary disease worsening, or the child is going in for any impending ARDS with secondary HLH. So either it could be the infection which is leading to secondary HLH, and we would like to aggressively treat the infection first. So it is a serious concern in this child.
In HLH, would you expect a liver dysfunction presenting as clinically recognizable liver dysfunction?
Sir, can present, but usually it can present with organomegaly, hepatosplenomegaly, but in later stages it can also lead to liver dysfunctions like transaminitis and jaundice in later stages. But initially it can present only with hepatomegaly.
Dr. Jagdish interpreted your findings as pleural effusion and maybe a lot of pleural effusion. How would you interpret your findings of reduced air entry, dull note, and fine crepitations in bilateral inframemory regions, infrascapular, and interscapular? That means up to highest area on the backside.
Sir, I would like to interpret these findings as it could be due to, however, there is no bronchial breathing, but it could be due to uh, uh, consolidation, patchy consolidations that can present with dull note and fine crepitations. But there is no stony dull note I could able to feel here. So I didn't consider pleural effusion as an interpretation. So one possibility I kept was it could be due to either pus within the parenchyma or fluid within the parenchyma, which can be due to HLH presenting with myocarditis leading to left myocarditis with leading to these uh, fine crepitations and dull note, or anemia with cardiac failure leading to this fine crepitations in the background of infection. So these can be the possible explanation.
Mild pallor is not that much anemia that will lead to
Yes, sir.
LVF. Very unlikely. Hmm?
Okay, sir.
So unless you are saying severe pallor, then maybe we can still consider that.
Okay, sir.
And with your heart sounds being totally normal, blood pressure being normal, tachycardia not totally, not much of disproportionate to, let's say, the temperature and such things. So again, cardiac problems are not very likely. So I would think that diffuse alveolar disease is what, with fine crepitations almost all over, at least posteriorly, that should be taken as, like, as you mentioned, like maybe a diffusion defect or such things, so that the hypoxemia is quite severe. This is 60% saturation. So 60% saturation on a SpO2 pulse oximeter, what would be the corresponding PaO2 in the arterial blood gas if we were to do that? Do you understand what I'm trying to ask?
Yes, sir.
So there is a pulse oximeter which is saying 60% saturation, right? What is the definition of um, a respiratory failure on blood gas analysis? Do you know the correlation between SpO2, which is pulse oximeter, with a PaO2, which is blood gas oxygen? Do you know the correlation?
No, sir.
No, you don't know. You know it.
Okay, I think he's overwhelmed by so many things being poured into the chat box as well as from the lead discussant. I'm sure when he has a cup of coffee, will remember everything. But for the time being, I think we have a good case for a discussion. And
Yeah,
then
let's move to.
let's move to the differentials, Dr. Ram.
Yes. So the possibilities I would consider were still tropical fever with secondary bacterial pneumonia, or tropical fever with infection triggered secondary HLH, or any disseminated abdominal and pulmonary tuberculosis.
So there is a question in chat box. Why not HIV? Dr. Ram?
Yes, sir.
There is a question in chat box. Why not? Would you consider HIV as a possibility also, or
Yes, sir.
okay? Then it should could have been included in this if you say yes. Otherwise, if it is not likely, then it's not should not be there.
Okay, sir.
Dr. Chug, if there is nothing more, then like we can proceed with the investigations.
Sure.
Yeah,
Just
Dr.
a
Ram.
minute.
Yes, yes,
I would
please.
like to make one comment.
Yes,
Why we
please.
are not keeping the diagnosis of complicated pneumonia? Because as you told that child might be having pneumonia with complication and child may have prolonged fever. We have seen the patients which are having complicated pneumonia and fever may not. Suppose child is having necrotizing pneumonia, then there may be persistence of fever. So I think common cause still we should keep first, and then if child is not responding, then we need to think of other rare causes.
I
This I
think
would like
what
to.
Dr. Jagdish is saying now, it is more or less resonating in the chat box that if I get a child who has cough fever for the past 2 weeks, around 2 weeks, is not responding to antibiotics, usually what we see is what is being looked for and what is being probed into this. It's a complication which has not responded to antibiotics, which probably we should look into. If it is subacute kind of an illness, then of course in a country like ours, TB probably would come much above that. If there is a weight loss for 2 months, suppose on history, and then 2 weeks there is subacute illness which is going on persisting, of course such severe presentation at admission, it shows that it is not just one of them. The complications, but yes, as Dr. Jagdish and the chat box is saying, we should be focusing more on what is more common. And I think for the sake of completion, a lot of things has been put, but yes, let's proceed with the investigation.
Yes, sir.
Again, let's do the same thing if the lights are not moving.
Yes, sir.
You can unshare and share again, Dr. Ram. So till Dr. Ram does that, there are things in the chat box about ABG. One can have a look at that. But HIV is one of the things which is there. HIV with PCP. I think thinking of HIV is enough. Whether it is over and above that PCP and all that thing can probably wait till we have a confirmation of that. Um, uh, First respiratory disease with no respiratory thing. Yes, that is what there. But yes, subacute prolongish history. But What is important here is that the child has come to you hypoxic and severe distress with fine crackles. That is what is unusual.
Allergic alveolitis was also in a way mentioned.
Yeah.
Yes,
Is
so
that
we know it's primarily a parenchymal involvement here.
yes.
More than anything else. If you have such severe hypoxia, it is primarily a parenchymal involvement somewhere for some reason. And we are looking for connective tissue causes and infective causes, autoimmune, all those things. I think Dr. Ram is back.
And I think anthropometry is well preserved, we can say.
Yes. So
Because,
it is not that
yeah,
prolonged thing.
yeah,
That probably
yeah,
goes take you away from probably HIV also.
yeah. So that is means against some means either this immunodeficiency or
Yes,
retro.
absolutely.
Yeah.
So please, Dr. Ram, proceed.
Yes, sir. At admission, the complete blood counts revealed a hemoglobin of 9.3 with total count of 3,000, with polymorphs of 83%, lymphocytes of 13%, and a monocyte of 2.3%. Platelets of about 1.42 lakhs, with MCV of 81, MCH of 24, MCHC of 24.6, with a red cell distribution width of 14.7. Peripheral smear did not reveal any blast, but however, there is normocytic normochromic anemia with reduced platelet. So the electrolytes were within normal limits. However, there is about elevated AST and ALT, which is about 90 and 52, with total protein of 5.5 and albumin of 2.9 with normal bilirubin. CRP was 37 and procal was 0.349. So for the tropical fever workup, blood cultures were sterile. Dengue IgM was negative. Leptospira IgM was negative. There is no malarial parasites in peripheral smear, which was done twice. Scrub typhus IgM was negative. Vidal was negative with O and H titers of 1:20. So this is the chest X-ray of this child, which showed bilateral heterogeneous opacities with miliary mottling.
Okay, Dr. Chuk, sir, any comment on this radiograph?
Well, not a very well projected, but we agree that it looks like a miliary shadows. So if you see miliary shadows, what would be your differential diagnosis in given your patient?
Sir, my first possibility would be miliary tuberculosis.
Any second possibilities?
Sarcoidosis can also present with this miliary mottling like of features.
Okay. Sarcoidosis in this age group, does it present only with the
No, sir.
mainly respiratory illness, or would it have extrapulmonary involvement also?
It can have extrapulmonary involvement in the form of uveitis, any skin rashes, and in joint pain also, sir.
So, older the age group, more classical is sarcoidosis. Younger the age group, more non-classical is sarcoidosis.
Yes, sir.
Right? Okay. Any other possibilities you're keeping? Your patient has come from Bihar, so suppose. Can this be tropical eosinophilia? If you don't know your blood counts.
Like Loeffler's pneumonia.
Loveless, no. I'm talking about uh, something related to Bancrofty.
Okay, sir. Tropical pulmonary eosinophilia. It could be more like an alveolar opacities or
Alveolar opacities, unless they're coalescent, they may also look something similar.
okay, sir.
Okay, let's see if chat box is adding a more differential
So chat
diagnosis.
box is Dr. Jagish. Anything on this, sir? Would you on this left hilar region? Do you think it could be some maybe lymph node which on this particular projection may be missing?
Yes, since there
X-ray is basically
is a shift.
rotated, so it's very difficult.
Very
Yes,
difficult because hilar
but
lymph
yes,
node here
it does raise a possibility. But then since the picture is not that very good, so
Yes.
we can kind of
Because
keep quiet on that.
Because if we get this lymph node confirmed, then probably we will have a different set of differentials here.
Okay.
Dr. Jagdish, anything specific
I
on
think
this?
sir has already pointed out. Okay, so though X-ray is rotated and there are miliary mottling is there, okay, miliary shadows are there, reticulonodular pattern is there, but yes, diagnostic possibility is, TB is one possibility, but we need to think of other causes like some fungal infection or some other causes. PCP sometime may present with miliary mottling, but PCP in a normal child it's unlikely.
Yes.
So means in retro we have seen child may present with this kind of X-ray picture in PCP, but if there is no underlying immunodeficiency, then it's very rare.
Yes. So
If we look at the third rib on the right side, anterior end, is it bifid?
This
looks like, sir. Yes.
looks like
Third rib, anterior end.
third
Yeah.
anterior end.
Okay.
And yeah, but yes, sir, the chat box also talks about fungal infections, but in a child who is not immunodeficient, it will not be possible. And for a child with a preserved anthro, it is probably something which is going on for 1 or 2 months at max. Beyond that, less likely. So
Yes,
yes,
even the picture, radiological picture is not really suggestive of a fungal infection. No.
yes, because if this is the clinical history and examination and radiograph, the first possibility that one would consider is, you know, so let's proceed, Dr.
National
Ram.
disease.
The national disease.
Okay.
Yes.
Okay, Dr. Ramakrishna, let's move forward.
Yes.
Each time we stop him, the slides also stop moving.
Today there is a technical issue, but some things are beyond our control, sir. But
Anyway, he's doing
I think
fine.
we have
Yeah.
had a very good discussion as of now. Thanks to Dr. Ram.
Yes, we have sent gastric lavage for 3 days of AFB smear and MGIT smear, which did not reveal any AFB. But however, CBNAT revealed MTP detected, but no RIF resistance was detected. To screen for dissemination to other organs, we did ultrasound abdomen, which revealed hepatosplenomegaly, but there was no granulomas or any focal lesion. There is no ascites, no ileocecal thickening, no mesenteric nodes or any omental caking. HIV ELISA was non-reactive and there is no choroid tubercles, and parental X-ray of both father and mother and the sibling X-ray was also normal.
So how do you look for choroid tubercles? Did you look at it yourself or did you ask a ophthalmologist, and what would be the significance and if at all any differential diagnosis of choroid tubercles?
So choroid tubercles are specific to miliary tuberculosis, almost 100% specific of miliary tuberculosis, and it also indicates uh, more likely a disseminated miliary tuberculosis. So,
Sir, asking you have asked the ophthalmology help for this, no?
yes, sir.
Yes, please proceed.
Do you think you will be able to recognize it if you were given an ophthalmoscope in your hand?
Not that confidence.
Okay, I would encourage all the youngsters to look at the uh, use of ophthalmoscope in such situations. And of course, there are good pictures that can be seen on the internet and even YouTube, and then try to compare if you find any findings. Yes, of course, you can ask your ophthalmologist to help you confirm what you have found. Yes. Okay.
Yes, sir.
Dr. Ram, please
So Dr.
proceed.
Indu Khosla says that lymphoma is also a possibility. Earlier, she has said that mycoplasma is also a possibility. What do you say about this, Dr. Ram?
Uh, uh, Sir, for lymphomas, there are no any peripheral lymph nodes palpable as of now, but bone marrow involvement with stage 4 with any intra-abdominal or mediastinal chest X-ray didn't reveal any. So it could be a less likely possibility. This more the X-ray pattern, everything was pointing towards tuberculosis. So I'd be keeping in the back of the mind, but less likely that. So,
So now that we have a
Such
microbiological
possibilities which are
evidence,
being listed in the chat box, most of them would have somewhat larger shadows than miliary. even if
Yes,
they are
sir.
disseminated, whether lymphoma, leukemia, lymphangiomatosis, whatever, this very fine, clearly miliary shadows are not likely in uh, other diseases. That's what I would say. And at this stage, probably we can ask we can ask Dr. Joseph also to come in and tell us if there are any other, radiologically speaking, till the radiology, will there be any other differential diagnosis? A lot of things have been raised, points have been raised in the chat box.
Sir, I think the stage is set for Dr. Joseph to come after 3-4 slides
Yes.
when we have
Okay.
the issue coming up, because we
Okay.
are short of time. Otherwise,
Okay. I'll ask.
I would have
Okay, we can wait. Sure.
just please, Dr. Ram, proceed.
Yes, sir.
Interesting.
So he wants Dr. Joseph to come in. So actually, there is again a point of where we need to review our diagnosis and in the
Okay.
approach part.
Okay, we can wait till that. Right.
Yes, sir.
So
Currently, the child was started on anti-tubercular therapy at day 3 of admission at appropriate doses, with along with dexamethasone, which is started at 0.6 mg per kg, suspecting alveolar-capillary block because the child is having severe diffusion limitations. They were started along with ATT. So during the hospital stay, child does starting anti-tubercular therapy tend to throw persistent high-grade fever spikes with the declining in the blood counts in the form of low TLC, anemia. This 10.3, after this 7.3, we did give a transfusion, after which we increased it to 9.2, and from 1.42 lakhs it dropped to 85,000, 92,000. It was persistently having these pancytopenia and these high grade fever spikes. So in our hospital stay, the child is having persistent high grade fever spikes with persistent pancytopenia with declining trend in the blood counts. So we considered these possibilities in the form of healthcare associated infection with sepsis leading to bone marrow suppression, or a bone marrow infiltration by tuberculosis per se, or infection related secondary HLH secondary to tuberculosis, or a rifampicin induced thrombocytopenia. But however, the child is having these decline in cell count prior to the introduction of uh, anti-tubercular therapy, co-infection with other viral infection in the form of CMV, or an underlying connective tissue disease like SLE or JAA, along with macrophage activation syndrome with TB, uh, uh, looking like TB is lying over these and underlying connective tissue disease.
So this is the point where probably Dr. Joseph can comment, and Dr. As Dr. Krishnchuk said, because thereafter you will have the diagnosis in front of you. So this is the point of discussion on this slide.
Okay, thank you, Dr. Kamal. Let me very quickly explain why we have chosen this case to present. Because the child came with very common symptoms. Nothing unusual, nothing surprising: fever, respiratory distress, cough, and some rash and all that. Now, what has happened is many of us have got fixated like the story of the elephant: we hold the tail, we hold the trunk. This is not a child who came with 15 days fever, 12 days cough, and 5 days respiratory distress. There is a rash which has still not been explained. There has been a what is it called, mouth ulcer and an oral ulcer and some lip ulcer and all that, and some undocumented weight loss. So if you put all those things together, it will explain why Dr. Rama had to go through all those negative histories, because it is not the usual pneumonia with effusion empyema kind of a story. So that takes care of that. Second thing I wanted to highlight is in our unit, or at least the way we practice is, we try to make a differential diagnosis from the history. So for that, history has to be thorough, history has to be comprehensive. We have to also factor in the constellation of symptoms, all of them, with their respective durations. So if you think of a child with fever who has come with cough after a few days, has developed a rash, then all the tropical fevers and all that come straight into the picture. And then he goes and develops respiratory distress and all that, then one can imagine dengue also with pleural effusion and things. So that explains, what he was not able to clarify, why these weird thoughts were going on. I think nobody would have been more surprised than us to see the miliary dots on the X-ray, because that is not what we were expecting at all. We were quite under the impression that this child has got pneumonia, maybe with some kind of a alveolar involvement, but miliary is not what we expected, with 15 days of fever, 12 days of cough, and the undocumented weight loss. Having picked up malaria, obviously, we had to go and investigate for tuberculosis, and microbiologically, it has proven. In the chat, I saw somewhere that once a gene expert is positive, the story is closed. It is not closed, because tuberculosis can be a bystander along with other things. It can be underlying something, it can be overlying something, and so we have to continue with the rest of the thing. And then, of course, the fever, which has not subsided, and the counts which have persistently been low and falling, that is what has triggered these 6 or 7 differential diagnoses which are shown up over here. And one of these he will confirm in the next slide and explain. I hope these comments are helpful in some way, because otherwise what will happen is the chat box is full of all weird things. For example, why is this not HIV? It will not be appropriate to think of HIV in a child who's growing well, has not had any previous stories to suggest a perinatally transmitted infection or anything. So while HIV can cause tuberculosis, but the setting has to be seen and things like that. Same is for the fungus, the lymphoma, leukemia, and all those so many differentials we saw in the chat box. Everything has to be not picked up from one end. We can't just pick up miliary dots on the X-ray and say therefore it is this. It is a component of the total story with its respective durations based on which we have to narrow the differential. That's all right, Dr. Kamal.
Absolutely, sir. Beautifully put. And I think this is an overall summation of what we have. And now to uncover the mystery, Dr. Ram, please proceed.
Yes, sir.
Actually, in the interest of time, I had to, sir, delay your entry into this, because we have 3 more minutes.
Sir, for the investigating for the above considered possibilities, blood cultures, urine culture, CMV, DNA, PCR, ANA, and RA factor were negative. HLH workup revealed a ferritin of 1157 and a triglyceride was 322. A normal range with ferritin is between 30 to 300 nanograms per deciliter. Triglyceride less than 150 milligrams per deciliter is the normal range. Fibrinogen 2.59 milligrams per deciliter, 0.9 to 1.5 milligrams per liter is the normal range, and D-dimer of 922 milligrams per deciliter. So, coming to the serial liver enzyme strength, the child also after introduction of ATT, there was a gradual increase in liver enzyme, but day 9 of hospital stay, the AST has increased up to 261, which is more than 5 times the upper limit of normal, and hence we modified the ATT and put on a liver protective regimen. However, bilirubin was normal, and for these other viral hepatitis were also ruled out. So bronchoscopy was done, and all visualized airways were normal in anatomy, and we did not see any endobronchial lesion. And BAL was done because bronchoscopy and BAL was done because child is having continuous high spiking fever, being considering sepsis or any superadded bacterial infection or any fungal infection in our mind. We did a BAL to get a respiratory sample, and we sent for complete analysis. BAL for cytology revealed Zetan stain, which was positive for AFB, and there was no granuloma. TLC was 130 with neutrophil of 27, lymphocyte of 25, and monocyte 41. Gram stain and culture was sterile. Fungal smear and cultures were sterile. Gene expert again revealed MTB detected and no resistance was detected. So, in view of persistent cytopenias, we proceeded with bone marrow aspiration as well as biopsy. The bone marrow aspiration revealed hemophagocyte, which is phagocyting a red cell along with megakaryocyte within it, and the bone marrow biopsy revealed a recognized epithelioid cell granuloma with central caseation. So hence it was as per aspiration there was hemophagocytes, but bone marrow biopsy revealed a caseating granuloma in the bone marrow, making a diagnosis of miliary tubercles or bone marrow infiltration by the tuberculosis. So at final discharge diagnosis, we kept us disseminated miliary tuberculosis involving the lung and bone marrow with infection-induced secondary HLH with drug-induced liver injury, and the child was afebrile 24 hours prior to discharge, and child was discharged. As the child is on DILI and is on alternate ATT regimen, we followed up the child after 7 days with LFT, and LFTs was declining trend, and every 3 days we have gradually introduced the ATT drugs, starting from rifampicin, followed by INH, followed by pyrazinamide. And by day 14 of in after discharge, the child was put on first line ATT HRZT regimen at appropriate doses, and at 2 weeks child has been followed up. There was no fever. Subjectively, cough has been improved 75%. ATT the child was taking with good compliance, and doses were reached which was adequate. And as the child fever as well as these cytopenias were also improving, and hepatosplenomegaly was also resolved, and steroids were started to taper at 0.6 mg per kg per day, 25% every week. So the Z score trend we just calculated. Initially, there is a rapid increase in weight gain, which the child was on steroid and was started tapering from 2 weeks, and it was gradually tapered and stopped at 8 weeks. And after which there was a gradual increase in weight gain with increase in height also. Thank you.
Thank you, Dr. Ram. I think you have done a very good job, well presented. A lot of things, when the discussion goes on, some things can come unexpectedly. So I understand that, but I think a very well presented case. Dr. Krishan Chuk, sir, you are before that, Dr. Jagdish.
Dr. Rama, when did you first suspect means HLH in this child? After how many days? Once you diagnosed TB, then when did you suspect? Based on your investigation, this cytopenias or means persistence of fever?
Sir, initially this hepatosplenomegaly we thought of a part of abdominal tuberculosis per se, but these cytopenias were still persistent along with persistent fever spikes, and child was also not improving, and gradually we also thought of HLH and worked up for the same.
Okay. Because sometime in TB we have seen that fever may remain for sometime 2 weeks, 4 weeks. We have seen patients who are having persistence of fever to 4 weeks. So usually if fever is there, then usually we don't suspect this HLH. But yes, definitely there is cytopenia. The diagnosis is, and you have proven the diagnosis. So that's what want to say. And one more point I would like to make here, that no rifampicin resistance. Usually we use this term. Actually, it is rifampicin resistant not detected, because gene expert detect around 90-95% of genes for rifampicin resistance, but still there are 5% chance that child might have rifampicin resistance. So I think culture would be the best modality to define drug resistance. These
Dr.
2
Ram,
points.
thank you, Dr. Jagdish. Thank you so much. Dr. Ram, was he getting his ATT from dots?
Yes, sir.
So it explains the doses that are there. Something when the dots, when the patient is on dots, some based on the weight band, you can have a bit of lower or higher end dosages in some cases. So there was a question in chat box. Dr. Krishan Chuk, sir,
I have a
any final
question for
comments?
Dr. Joseph and everybody else can comment. If a patient is suspected as tuberculosis or is having tuberculosis, and from the very beginning has very high fever, is that a sinister sign? Does it say that this child can go into complication, that this child is more likely to have a TBM, this child is more likely to have biliary? Is that a true statement?
Sir, to our knowledge, neither the degree of fever nor the duration of fever predicts that, because TBM has been diagnosed in children with 3 days fever sometimes, and the dictum of 2 weeks, cough 2 weeks fever is only to suspect. But there are cases on either side. So children with less than 2 weeks also have turned out to have TB, and children with longer durations of fever have turned out not to have TB also. The only thing is, once we suspect or identify TB in one side of the body, then it is necessary to rule out all the other sites. The only thing which we have not looked at is actually neuroimaging. Because, and the reason for that is because amongst all the patients of this that we have with TB, we have so far only missed one child by not doing the neuroimaging. Otherwise, if the child is asymptomatic neurology wise, we don't routinely image the CNS because it involves MRI and things like that. But one child we had about 9-10 years of age, we didn't do the thing, and then after a few days he had a convulsion, and then when we did the MRI, he showed up florid TB, but he had no neurology symptoms when he started. So other than that, we have looked at abdomen, we have looked at eye, and if there is a lesion in the bones, then we take bone x-rays also and the parental screening. So the TB workup, somebody had asked in the chat box, why 3 times gastric lavage? Children are paucibacillary generally, intermittent shedders. So we have data to show that the more frequently you do the sampling, the more likely you will pick up. And earlier the dictum used to be 3. Then for operational reasons, it has been brought down to 2 and 1 and all. Our median number where we get the maximum yield is 5. So 3 we do routinely. And then if that doesn't work, we go ahead with a bronchoalveolar load in pulmonary or suspected pulmonary.
Thank you so much, sir. Dr. Chuk, sir, anything else, sir?
That's
Thank you.
it. Maybe in the last, when HLH was being talked about, that chart of the diagnostic criteria could have been put just to refresh everybody as to what are the diagnostic criteria for HLH.
It is there, sir. If you want to unhide Dr. Rama, you can unhide. But 2004 criteria are the standard. There are 8 points in that. 2 of them are a little complicated in our setting. That is because it involves some genetics and all. But 6 of the other 6 he had this child. You got that slide, na, Dr. Rama?
Yes, sir.
So are you able to unhide it so that while everybody's talking, it can just be projected?
I think 5 out of 8 criteria is
5 out of 8.
5 out of 8, correct.
5 out of 8.
Yes. So
there
I
is
think
a revision to that criteria also in 23-24, where they have dropped 1 or 2 which are not usually done. So anyway, that 8 still remains the gold
yes,
standard.
I think there are enough for this to be called as a challenge. So for the rest, we have literature available for everybody. But I think there is one point that I would like to make. We are here to discuss science. We are here to make scientific justifications for whatever we're giving. We will not point fingers at the treating unit or the presenter here. He is somebody who is still in his learning stages and he will turn out well, I'm sure about this. So I would suggest that we should keep it non-specific and scientific only. And the presenter and the presenting team has done a great job for us. They have done a favor to us by this nice presentation. And from my side, Dr. Ram, thumbs up to you for a very nice presentation, and Professor Joseph for very nicely guiding this. Thank you so much from my side. And yes, over to Dr. Modi and Dr. Rawat, sir.
So thank you very much, Dr. Ramakrishna, for an excellent case, excellent discussion, and lot of lateral thinking and out of the box thinking also. I'll thank Dr. Joseph for excellent moderation, Dr. Goyal and Dr. Kishan Chok for being expert, and Dr. Kamal Singh for, as usual, an excellent moderation of the case. Thank you very much. So we again meet next month in the last Monday with another case. Till that time, goodbye, good night from all of us. Thank you.
Thank you so much.
Thank you, sir. Good night all.
Thank you.
Good night.